Good afternoon, distinguished delegates, colleagues and friends. My name is Dr. Ryan MacFarlane. I'm Vice President at Access Partnership, and it's my pleasure to serve as the moderator for today's APEC Policy Dialogue on Reducing Influenza Burden in the Elderly. And so on behalf of the organizers, we'd like to welcome and thank you for joining what we hope will be a practical and forward-looking discussion. For those online, I have to say we definitely lucked out. We have a beautiful room here. I can actually see palm trees to my right, which coming from Washington, D.C., where we are currently encased in ice. It is actually very nice here in Guangzhou. This is actually the fourth day of health working group related events. We've had a number of different discussions on healthy aging. Just this morning, I was able to participate in a workshop on respiratory disease and respiratory infections. And today we're actually combining those two issues in terms of healthy aging and respiratory disease. And for those who may not be familiar with some of the previous work on this topic, this dialogue builds on the momentum from the APEC SOM3 2025 policy dialogue that was held in Korea, where economies came together to examine the growing impact of influenza on older adults and the importance of prevention in aging societies. That discussion underscored both the scale and the challenge and the need for stronger, more coordinated policy responses. And since that discussion, we have circulated to the APEC Health Working Group a summary paper highlighting 6 practical recommendations that provide a roadmap to strengthen resilience, protect older populations, deliver health and economic returns. And just to show how intensely APEC economies view these documents, it is still being actively circulated, and we are waiting endorsement from the Health Working Group any moment. And so today moves that conversation forward, and rather than focusing on only the problem, we will also concentrate on economy level progress since SOM3, how evidence is being translated into policy, and how surveillance and data systems are evolving, and how those economies are considering improved tools, including enhanced influenza vaccines to better protect older adults. And anyone sitting in the back, you are welcome to join us here at the table. There's plenty of room there. So across the Asia-Pacific region, populations are rapidly aging. We've heard a number of different discussions on how fast the Asia-Pacific region is progress. Aging, so that will come as no surprise to anyone here. But we will look at, in terms of with that longer life expectancy comes a growing responsibility to ensure that the added years are lived in good health with independence and quality of life. Influenza may be seen as seasonal, but for older adults, it can be life-changing and life-threatening. It is a major driver of hospitalizations, functional decline, and worsening of chronic conditions such as heart and lung disease and premature mortality. But the good news, not to be a total bummer here, but there is actually good news, is that influenza is preventable. And what is really exciting is we actually now have effective tools, especially vaccination, to reduce severe illness and complications. And strengthening influenza prevention is therefore not just about infectious disease control. It is a core component of healthy aging policy, helping older adults remain active, independent, and engaged in their communities, while also reducing the strain on health systems. So today's dialogue will bring together policy leaders, researchers, and public health experts to explore how we can better use these tools grounded in evidence and informed by economy experience, and then adapted to the diverse health system context across APEC. So if I could have the next slide. So before we begin, just a quick housekeeping note. Today's session will be recorded, and we do plan to make the recording available online so that others may benefit from today's presentation and discussions. So just want to take a brief moment to see if there are any objections. Thank you for that. And then if we have the next slide. So just in terms of interpretation, and we do apologize, we are having some technical difficulty with the Vietnamese interpretation, but we will try to work that out. But we have planned to offer live interpretation in Mandarin, Vietnamese, and Korean. For those joining in person, you can scan the QR code that you see right there and follow the instructions to connect to the interpretation on your phone. You will need to use your own headphones. Once logged into Zoom, you'll be able to select the channel for your language of preference. And then a kind reminder, everyone in the room, just please always use a microphone when speaking so that our interpreters and our virtual participants, which I know we have quite a few participating online, can hear you clearly. And for our colleagues that are joining virtually on Zoom, welcome. We're glad that you're a part of this discussion, and you may please submit your questions at any time using the chat function. We will monitor this chat and bring your questions to the Q&A segment later in the program. And you can see there, for those participating online, how you can choose your language of preference. Have the next slide. Okay, so I just want to briefly walk through the agenda for today's meeting. We will start off with some opening and scene setting remarks to frame the influenza burden in older adults and the broader policy context. We will then move into real-world evidence from Korea on vaccine effectiveness in aging populations. And then next we will hear several APEC leadership case studies, including from Chinese Taipei and Japan, highlighting how economies are translating evidence into policy, including pathways towards enhanced influenza vaccines for older adults. We will then broaden our lens to a regional level, examining system gap surveillance challenges in the often under-recognized burden of influenza across the Asia-Pacific. And then we will also hear about the FLUNITY study, FLUNITY-HD study, which provides important new evidence on the effectiveness of enhanced influenza vaccines in preventing severe outcomes. We will then conclude with an interactive Q&A discussion, followed by a short summary of key takeaways. So do keep your questions ready. We will have all the Q&A at the end, but there may or may not be prizes for those who ask questions. So do please have those questions ready to go. And so with that, we go to the next slide. So with that, to begin our program and help frame today's discussion, it is my pleasure to introduce our first speaker, Professor Reuben Ng. Professor Reuben Ng is an assistant professor at the Lee Kuan Yew School of Public Policy at National University of Singapore. He's a behavioral and data scientist whose work focuses on how public discourse, social perceptions, and policy environments influence health behaviors and population outcomes, particularly in the context of aging and public health. And today, Professor Ng will help set the stage by exploring how influenza and vaccination are discussed and perceived, and why these narratives matter for policy and uptake. So, Professor Ng, thank you for being with us, and the floor is yours.
Thank you so much, Ryan, for that generous introduction. So good afternoon to all of you. Thank you, and hope you enjoy your lunch. So my name is Reuben Ng, as you can see on the slide there. NG has no vowels, so it's always difficult to pronounce. So when I spend some time overseas, people always think NG is an abbreviation for no good. But I told them, no, it's not no good. It's a nice guy. I'm from Singapore, so maybe just a quick introduction. Singapore is 4 seasons: early summer, midsummer, late summer, and summer. So every day is really hot and sweltering, so it's nice to be in beautiful and cool Guangzhou. But I think Singapore has 2 seasons, indoor and outdoor. If you've been to Singapore before, indoor is always freezing cold with the air condition. The AC outdoor is just sweltering hot. So there's no good time to visit Singapore, but there's also no better time. So welcome you to come anytime. Okay. It doesn't look like this is my first slide. Is there a... Okay. Okay, so maybe just before talking about, I think the slides got switched around, but the idea here is that, influenza mortality rates are a lot higher for 65 years and above compared to other groups. Now, this is an important, can I just see the next slide? Okay. Okay, so before maybe moving to this slide, I just wanted to give some background about the aging populations in the world. So everyone is talking about the aging population because the numbers are quite stark. There are some United Nations projections that by 2050, there'll be 2.1 billion older adults, 60 years and above. So what 2.1 billion means is the entire population of US and China combined and more, right? So which means that aging is going to be sort of an important key demographic driver. But the other important thing also is that, I've done a lot of stereotype research, and we found that most of the time when we talk about older adults, 3 in 4 would talk about older adults to be in a very negative sort of fashion. In fact, on media, for every positive descriptor of older adults, we have 6 negative ones. So it's quite a serious issue. It's serious because there are two implications for this. First of all, there are a lot of studies showing that people who think negatively about aging lived 8 years shorter than those who think positively. Okay, those who think negatively about aging also have an earlier onset of hearing losses and a higher risk of recurrent cardiovascular disease. Okay, so it's not just to individual health, but also to population health. There have been a lot of studies in the US, in Europe, and the UK showing that the cost of negative healthcare stereotypes for aging actually cost the US healthcare system in excess of $63 billion. Okay, so because of that, there's an urgent need to reframe aging from one of a burden to one of a blessing, right? And one of the key ways to then reframe aging, have a more positive conversations around aging, one of the key things is preventive health. And one of the key planks is vaccination, enhanced flu vaccinations, right? So I think we want to reframe aging because the world is aging. And one of these key strategies is really vaccination. So I just wanted to set the stage, okay? This particular slide is something I'm very excited about. So I'm a behavior and data scientist. We put together different kinds of data sets to understand narratives, because without understanding narratives, there's no way we can change behavior, right? So what we did was everything that's been published across these 20 countries, we collated online media from 2010 all the way to pretty much last week. So we could look at then the narratives of different conditions. We can look at flu. We can look at whatever kinds of conditions. So this really gives us the pulse of society, what people are talking about, what are some of these narratives, are there misinformation, disinformation, and so on. So we use this particular platform, for example, to understand policy communications. Prior to the university, I was working in the government, and sometimes from a perspective of a policymaker, what we intend to communicate is often not how it's perceived. So we try to do a dynamic understanding of how policy communications are done, how it's interpreted. If there's some misinterpretation, then we can correct it in the next news cycle. So this is the kind of platform that we use. Next slide. Okay, so what we found was quite interesting. We wanted to look at the sentiments around flu vaccinations in the news media. So the gray band is neutral. The blue band on top is positive. The red band is in the negative zone. So it's interesting that in news media, the narratives of flu vaccines are quite neutral, from neutral to positive. Now, I want you to take a look at the next slide, and that's social media. Social media, as you can see, is trending negative. Okay, so next slide compares both news media narratives about flu vaccines and social media. We can see a disillusionment gap between narratives of flu vaccines in the news media and social media. Okay, so I think it goes to show that sometimes we may have some narratives that companies and organizations put out on news media, but it's important to understand the content of negative narratives on social media as a way to counteract it. Because at the end of the day, how do we get some of these vaccines to be subsidized in national immunization programs? Or in Singapore, we have this program called HWell-SG, where Singapore is fast. We have a demographic milestone this year where we'll become super aged. Super aged means that 1 in 5 will be 65 years and above, right? So the idea here is not just what are some of the policy narratives that we can put in place, but question is there some narratives we can create from a groundswell perspective? Right? So I think from a groundswell perspective, if we can create and seed some of these narratives, then older adults, their family members, and their caregivers would be asking for these things. And that's a good way to get some of these policy changes and shifts. We can accelerate some of these things. So we kind of need to do not just a top-down, but also a bottom-up perspective to achieve some of these policy objectives. Okay, let's see what we have as the next slide. Okay, so my session is really to set the stage for some of the distinguished speakers that will be coming, countries' case studies, and looking at some of the evidence. Now, the objective of this particular dialogue really is to look at real-world evidence on influenza burden and vaccine effectiveness among older adults. And I should mention also that sometimes when we look at older adults, we just lump them under 65 years and above. in gerontology or the aging world, we realize that sometimes we need finer age bands because somebody who is 68 is very different, has different set of needs from somebody who is 88. So the three age bands beyond 65, young old, which is 65 to 74, mid old, 75 to 84, and 85 and above will be oldest old. Okay, and it's really important to think about how some of this real world evidence, not just to 65 years and above, but really for those different categories of old age, because as we know, the risk increases as somebody ages. The second point is really to discuss and to talk about policy pathways towards enhanced influenza vaccines in aging societies. For example, some of those pathways might not just be policy related, it could be groundswell related, getting people excited, getting people to request for some of these things. I think if we can do some of these things in tandem, we'll see policy changes accelerated. Number three is to identify system gaps in surveillance, data, and implementation. And I would say when it comes to the system gaps, we also need to look at narratives because narratives drive behavior. Fourth is to support cross-economy knowledge sharing to sustain policy momentum beyond the meetings that we have here. Because I think together, everyone sort of achieves more, and to see whether we can create not just a groundswell within a particular country, but across APEC as well. Okay. With that, thank you very much.
Excellent. Thank you very much, Reuben. That was fascinating in terms of looking at how psychology, narratives, and behavior actually drive real-world outcomes. I know after hearing that, I'm definitely going to try my best to put positive vibes out there about healthy aging and vaccines going forward. Okay, so in terms of our next speaker, I'm very pleased to introduce Dr. L.J. Tan. Dr. Tan is the Chief Policy and Partnerships Officer at Immunize.org and co-chair of the Global Influenza Initiative. He has held numerous leadership roles in immunization policy, including service on U.S. national advisory bodies and longstanding work to strengthen adult and influenza vaccine programs globally. His work focuses on vaccine policy, access, and delivery systems, particularly for adult and high-risk populations. And today, he's going to help us frame the broader policy landscape for influenza prevention among older adults. And so, Dr. Tan?
Thank you very much, Ryan. Really appreciate being here. Thank you, Reuben, for that setup. I think a lot of what I'm going to talk about is going to follow very naturally on what Reuben has talked about. I happen to be getting towards that younger old population. And so I think I have a very strong personal interest in the fact that I want to be protected against influenza as I hit that young old population range, right? So my job for the next 10 minutes is to kind of just build on what what Reuben has kind of Dr. has kind of said. See, I'm originally from Singapore, so it's kind of, you got two Singaporeans up here kind of doing this, but I've been living in the United States for over 35 years now, maybe 40 years. But that being said, I'm delighted to kind of follow up on some of the objectives that was mentioned by Dr. Ng and kind of bring it off, kind of show you what that was like as a result of the SOM 3 meeting that was held in Incheon in August. So if I could have the next slide. This is to just basically kind of set the scene and remind everybody, and this has been already very nicely covered. So what I'm going to focus on here is basically the first box, which reminds everybody that I'm going to actually kind of summarize a recommendation paper that, as Ryan has pointed out, is still very effective, still being used. Obviously, it should be because it's very, very relevant. And that paper around everybody is titled Preventing Influenza-Related Immunizations and Deaths Among the Elderly to Promote Healthy Aging in the APEC Economy. So something to keep in mind, that paper is available. The burden of influenza is in the green box. I'm not going to spend a lot of time on that today. Reuben has already mentioned a little bit of that. And I will actually spend a little bit more time on the burden of influenza in my final presentation, which will follow John here from APACI. So my job for the next 8 minutes or so is to basically talk about the 6 priority recommendations that came and to remind everybody that they tie into what Dr. Ng has talked about. So if I can have the next slide. If you think about recommendation, I want to point out that as a result of that paper, and we will hear from these economies soon, I want to point out that there have been movement forward. And so since we're hearing from these economies, I'm not going to go ahead and spend a lot of time talking about their success and what they've been doing with regards to enhanced influenza vaccines, but move on to the next slide and focus specifically on the 6 recommendations. So the first recommendations, remember, these 6 recommendations are all addressed to kind of move us towards understanding the best way to improve access to enhanced or better influenza vaccines as a result of data, right? So again, we need to make sure that we're putting it all together, okay? So the first recommendation is obviously very clear, right? If you have a better vaccine, you need to follow the science and you need to develop policies that enable the use of those better vaccines. So if we talk about following the science, we talk about evidence base. If the evidence base shows you have a better vaccine, you should be following that evidence. Okay, so that's something that's really important to keep in mind. And what does that mean by following that evidence? It means you got to create policies that remove barriers to access. So if your patients, if your public over 65, over 75, over 85 cannot get to what is data showing as a better vaccine, you need to think about changing that policy. So this is the first step of access. You'll hear me talk a little bit more about access in another recommendation further down the line. And so what do we need to do? We need to make sure that a lot of these barriers in policy are removed. And that means sustainable funding, that means multiple channels, and we can talk a lot about that. The paper really goes into a lot of that. And one of the things I would like to point in mind, something that we have used in the United States, although currently we're taking that off the table a little bit for reasons I think many of you might know. We used to use incentives to drive provider performance. So basically, if a provider or a physician or a clinician performs to a certain level, I get 90% of my patients vaccinated, there would be an incentive, right? So those are things to consider in terms of enhancing your policies to improve access to vaccines. The second slide is recommendation 2. And this is about improving vaccine uptake through outreach and public awareness. So if we can have the second slide, please. Thank you. So if you are now improving access through your policies and you're pulling your providers along, the next thing you got to figure out, and Dr. Ng mentioned this, right, with that gap, is you got to bring the patients along too, right? And that means you're going to have to go ahead and reach out to these patients. You're going to have to make sure that they know the benefits of flu vaccination. And then you need to make sure that your communications are targeted at the right audience, which is these older populations that Reuben has talked to us about, to their caregivers, the people who are taking care of these folks as well. Because remember, all it takes is for a caregiver to say, huh, flu vaccine? And all of a sudden, you've lost the patient. So you got to make sure you have targeted communications and talk about the benefits of these vaccines. And there is a good leverage point. If you have a quote unquote better vaccine, that means you can tell your patients and the caregivers that we're actually trying to get a, right? So something to keep in mind. The other thing also you want to keep in mind is that you need to make sure that there's an access challenges also addressed. We talked about access challenges because of policy. Think about access challenges because of barriers, right? So older folks have a harder time finding vaccines. They have to move to a place to get vaccinated. So you got to remove all of those things. So ultimately what you have to do is you have to make it convenient for your patients to get vaccination. So convenience is the access that you have to remove, whatever that means. And then when you do all this, you need to make sure you continue to measure how well you're doing, right? You need to say, hey, if you're doing these programs, if you're educating your patients, you're educating your caregivers, are we actually seeing improvement? And if not, you need to find out why. And that's that accountability at the bottom there. Next slide, please. One of the biggest things when I go talk globally about influenza and other respiratory viral diseases is about surveillance. If you don't look for something, you're not going to see it. And if you don't see it, it's really easy to say you don't have it, right? I think you need to keep that in mind. So I think we need to make sure that we improve our surveillance systems and in general, improve data, because that first point is remarkably important. If you have better data, you will have better policy, assuming, of course, you are evidence-based, right? And that's what we want to make sure we do. So better data is not just surveillance data, which I've already mentioned, it's also coverage data. How well are you doing with your vaccination coverage rates? Surveys about your patients. Reuben has showed us some, right? He does that survey. Are the patients accepting the vaccine? And if not, find out why, right? So that's data that can improve your policy as well. And then finally, the way you get that data has to be transparent. It has to be available for everyone to know what you're doing, because that will then create trust. And as Reuben has been talking about earlier, that is trust in you, but also that is trust in the vaccination process. That's incredibly important. Next slide, please. Recommendation 4. Obviously, this one is a no-brainer, I think, in many of us, is that as you do all of this, it would be foolhardy to not be able to think about, detection, surge preparedness, and treatment, because the older adult is indeed vulnerable to flu. And you need to be able to have diagnostics to detect influenza infection in those who are older. And if you are older and you have flu, you want to treat them, right? And so that means you need to have diagnostics to diagnose, then you need to have treatments, antivirals available to treat. And in the United States right now still, we recommend that you treat without confirmation. If you have an older adult or someone who's at high risk and they appear to have influenza, you treat with an antiviral even as the confirmation test is going on. In the United States right now, it's very, very kind of neat. They have now these over-the-counter tests that test for both COVID and flu. Very nice. I used one myself a couple of months ago. It turns out I had COVID, but that's okay. It wasn't flu. But then the other final thing to remind everybody also then is that as you test, as you treat, remember that when seasonal surges happen, you need to be prepared for those seasonal surges, right? So in other words, you need to have your antivirals ready to go. You need to have those diagnostics ready to go. And you also need to have personal protective equipment, et cetera, ready to go. Next slide, please. I'm running out of time, so I'm going to try to wrap up very quickly. This one is a no-brainer in many respects as well. The long-term care facilities are where all your vulnerable adults are sitting. These are people who will suffer, who will die if they get influenza. So we need to do better with those folks. So we need to focus into these long-term care facilities, get them protected. And then the other thing also is to remember that once you have an outbreak in there, it will go crazy. So you need to be ready to prepare against outbreaks should they happen, which means you've got to have plans ready for infection control, whether that means cohorting, whether that means visitor precautions and restrictions, et cetera, those plans need to be in place. And then finally, as I said, the vulnerable are in these facilities. So if there is an outbreak, you need to have those antivirals ready and you need to give them. Next slide, please. And finally, I think this is incredibly important in the context of what Reuben has talked about. We need to make sure that our influenza prevention strategies and controls, treatment, prevention by vaccination, et cetera, are all integrated into the holistic environment of healthy aging. So if you have someone coming in for a checkup who is older, you should be thinking, weight, blood pressure, cardiac exam, vaccination. It needs to be implemented in those routine care primary pathways so that it is a no-brainer for your clinicians, for your providers to do that. And then what I can tell you, and this is indeed true, and I'll show you a little bit of this in my next presentation at the end of this session, is that if you do this right, not only will you be saving lives and improving the quality of life for those of your population that are older, you will actually be delivering cost effectiveness and cost savings to your economies as well. Last slide, please. I'm going to stop right here. Thank you all very much for your attention, and I'm delighted to hand this back to Ryan.
Excellent. Thank you, LJ. I think that was a great presentation of the recommendations. I mean, a lot of them are kind of common sense, but I think it really helps to lay them out as you have. I mean, particularly if we have, a better vaccine, we have a better mousetrap, we should be using it. Incentives drive action. I know I have 2 young kids, and certainly they are very motivated by both money and access to video games. So I can definitely say that incentives definitely do matter. We have to make it convenient. You have to meet people where they are. And I think no data doesn't mean no problem. So we do need to collect data. And if we do have better data, we will have better policy. So thank you very much for that, LJ. So our next speaker is Dr. Won-Suk Choi. He's a professor of infectious diseases at Korea University College of Medicine. He's going to speak on some of the real-world evidence that has been generated through at Korea. He serves on multiple national advisory committees and immunization and health crisis response, and also chairs the Adult Immunization Committee of the Korean Society of Infectious Diseases. His research focuses on vaccine effectiveness, immunization policy, and infectious disease burden in aging populations. And as he's going to share some recent findings on influenza vaccine effectiveness in older adults. And we're very pleased to have Dr. Choi online with us, although we're actually going to show a video just because of some of the technical challenges we were having earlier today. So we're going to show a video, but Dr. Choi is actually is with us to participate during the Q&A session. So can we cue up that video?
Good afternoon. Thank you for this opportunity to speak today. My name is Choi from Korea University College of Medicine. Today, I'd like to share real-world evidence from Korea and discuss policy implications for influenza prevention in older adults. My key message is simple. In rapidly aging societies, standard dose influenza vaccination strategies are no longer sufficient, and we need to consider more effective approaches. The Asia-Pacific region is aging faster than any other region in the world. By 2050, 1 in 4 people in APEC economies will be over 60 years old. This demographic shift is already shaping our health systems. At the same time, influenza remains a major cause of hospitalization, mortality, and economic loss through healthcare costs and caregiving burden. Therefore, protecting older adults from influenza is not only a health priority, but also a key issue for economic resilience and sustainability. Influenza does not affect all age groups equally. Among older adults, 65 and older, influenza-related hospitalization and mortality increase sharply. More than 70 to 90% of seasonal influenza-related deaths occur in this age group. Older adults are 5 to 10 times more likely to be hospitalized due to influenza complications. Influenza can trigger acute cardiovascular events such as myocardial infarction and stroke, making it a serious systemic disease in seniors. Let me see the real-world evidence. The hospital-based influenza morbidity and mortality, or HIM network, is a multi-center surveillance system covering 8 large university hospitals. It focuses on adults hospitalized with severe acute respiratory infection using a test-negative case control design. The object of this network was to evaluate real-world effectiveness of a standard dose influenza vaccine. Korea presents an important paradox. Among adults aged 65 and older, influenza vaccine coverage is close to 85%, one of the highest levels globally. So access and uptake are not the main problem in Korea. However, when we examine real-world effectiveness, the results much less reassuring. Vaccine effectiveness was only 13.5% older adults. In all others, it was 24.3%, and in younger adults, it reaches 36.2%. This shows that even with excellent coverage, protection in senior remains limited. This challenge is therefore not coverage, but insufficient immune protection in older adults. Another important issue is waning immunity. Vaccine protection declines within the same influenza season. Early in the season, effectiveness is higher, but later in the season, it drops substantially. This leaves older adults vulnerable during late season influenza surges, even though they were vaccinated. So, we face 2 simultaneous problems: a weak initial immune response and faster decline of infection. Let me turn to international experience. On this slide, I show data from the United States, United Kingdom, and Australia. Well, enhanced influenza vaccines are widely used in older adults. In the United States, vaccine effectiveness against influenza-related hospitalization in adults aged 65 and older has generally been recorded 30 to 40% in recent seasons. In the United Kingdom, surveillance data shows vaccine effectiveness in older adults, typically around 35% or higher. In Australia, national surveillance records indicate that vaccine effectiveness against severe influenza outcomes in seniors is commonly in the 30 to 40% range. These figures are clearly higher than the 13.5% observed in older adults in Korea. This suggests that the difference is related not only to age, but also to the type of vaccine used. This slide provides more direct evidence. In France, a large national cohort study using insurance database shows that the high-dose influenza vaccine was 27.4% more effective than standard dose vaccine in preventing influenza-related hospitalization among adults aged 65 and older. In Spain, regional real-world data shows that high-dose vaccine provided about 34% protection against severe influenza outcomes compared to standard dose vaccines in seniors. In addition, meta-analysis combined data from multiple countries consistently confirmed that enhanced vaccines reduce hospitalization and serious complications more effectively than standard dose vaccines. Why do standard vaccines perform less well in older adults? The main reason is immunosenescence or immune aging. With aging, antibody response are lower and decline more rapidly after vaccination. Standard dose vaccines often do not provide sufficient immune stimulation to overcome this biological limitation. Highly immunogenic vaccines help address this problem. High-dose vaccines increase antigen exposure, and adjuvant vaccines enhance immunization. In short, enhanced vaccines are designed to compensate for immune aging. Enhanced vaccines are more expensive per dose. However, policy decisions should focus on the value, not price alone. If enhanced vaccines prevent hospitalization and ICU admission, they can reduce total healthcare costs. Importantly, cost-effectiveness analysis have been conducted in Korea, and these studies show that highly immunogenic influenza vaccines can be cost-effective for older adults. So, the economic argument is not only international, but also relevant in Korean context. Based on this evidence, I propose three strategies. First, prioritize enhanced influenza vaccines, such as high-dose or adjuvant vaccines for adults aged 65 and older. Second, adopt value-based procurement using real-world evidence rather than focusing only one unit price. Third, strengthen regional collaboration within APEC to harmonize influenza surveillance and vaccine effectiveness evaluations. In conclusion, older adults remain the most important target group for influenza prevention. In Korea, vaccination coverage is very high, but real-world effectiveness in seniors is still low. This clearly tells us that we need a better prevention strategy for aging societies.
Excellent. Thank you very much, Dr. Choi. I think that was actually a beautiful representation of what LJ was saying earlier, just in terms of the importance of following the science, following the evidence. So I think presenting those studies, I think, really brought that home. And certainly what you're saying about immunosenescence certainly makes sense to me. I'll be turning 50 next year, and I certainly do not get over jet lag as easy as I used to, don't get over going to the bar as easily as I used to, and also my kids now will bring home some sniffles, and I'll be sick all winter. So it definitely makes sense to me. So now in our session, we're going to move on to the APEC leadership cases, policy pathways to enhance influenza vaccines. And our first APEC leadership case comes from Chinese Taipei. And so we are very honored to have Dr. Yi-Chun, who's Director General and Specialist in Infectious Diseases. He has played a key role in outbreak response, risk communication, and vaccine policy during the COVID-19 pandemic. He served in senior leadership roles within the Central Epidemic Command Center, and today he will share how Chinese Taipei is strengthening influenza protection for older adults and translating evidence into vaccination policy. And so, Dr. Lo, we're very pleased to have you attend virtually, and the floor is yours. I don't think we could, you may be muted, Dr. Lo. We cannot hear you here.
Can you hear me now?
Yes, we can.
Thank you, Ryan. So good afternoon. It's my pleasure to share the experiences from Chinese Taipei about the pathways that we have recently gone through to officially endorse enhanced influenza vaccines as our policy. Enhanced influenza vaccines, as the professors has already described, are among many of the new vaccines that could have significant public health benefits. And a big question for our policymaker is how could a new vaccine be endorsed as a policy? That would involve governance and the financing mechanisms. In our example, we have a law that mandates a vaccine fund for vaccine purchase and program expenditures, and the fund's financial input was kind of sustainable, mainly coming from annual budget and tobacco health surcharges. The law also mandates an approval process for all new vaccine purchase be based on ACIP recommendations and prioritized by cost effectiveness studies to avoid political influence. As shown in the graph on the right, a large input from annual budget occurred during COVID for us to respond to the surging need for COVID vaccine purchase. However, the input reduced after COVID, and we were still being able to keep it higher than pre-pandemic era in order to first accommodate more demand for administration and the preparedness cost, and hopefully in the future for adopting new vaccines. However, for 2026, we literally didn't have any additional budget into the new vaccine purchase. The reason that input into the vaccine fund does not prioritize new vaccine purchase is related to our post-COVID health challenges. As many of you have mentioned, our population in the region and also in my economy is rapidly aging. We have officially become a super aging society at the end of last year. We have also been facing healthcare workforce shortage, surge of various respiratory infections, and continued vaccine hesitancy, particularly among elderly adults. Therefore, the policy decision was before adding any new vaccine to overwhelm the healthcare system, we should have additional investment going to vaccination workforce first to sustain their capacity. Starting from next month, the vaccine administration fee per dose will be increased. And also there has been additional incentives given to the workforce as an award for vaccinating priority groups such as the elderly population. We have also established more private partnerships such as industry with supermarkets and the celebrity as shown in this picture to advocate vaccine confidence. as well as efforts and quick actions and transparency to vaccine-related events or misinformation. With this work, we want to promote healthy aging through public trust and a better uptake of influenza, COVID, and pneumococcal vaccines, all offered currently free of charge to adults with eligible criteria. And for updated vaccines, for pneumococcal vaccines, all upgrade to a newer version will be ongoing this year, and that wouldn't add any significant cost to our program. However, for enhanced influenza vaccines, the price is higher, and elders in the long-term care facility has been announced to be the first group to start receiving them in October this year. That will be around 200,000 people, a relatively small additional cost incurred around $25,000 to the program, which can still be covered by the balance reserve in the vaccine fund. Before announcing the new policy, actually a cost effectiveness analysis similar to what Professor has described was already carefully conducted locally by an independent institute in 2024 for the two available enhanced vaccines, adjuvanted and high dose. The conclusion of the analysis was, compared to the standard dose vaccines, both enhanced vaccines further reduce influenza-related visits and hospitalization. And cost effectiveness can be achieved with lower than market price, which is a good news for our price negotiation. Also, the benefits are better for the more extremely aged groups above the age of 75. The results were presented in our ACIP last year and led to the decision of ACIP's recommendation of changing to enhanced vaccines for elders as a priority policy direction. And despite no additional financial input in 2026, we're going for the new vaccine purchase. Given that the fund balance reserve was still enough, we decided to start enhanced vaccines in a smaller amount, 200,000 doses, to the elders in the long-term care facility first. We'll also conduct a survey this year to evaluate elders' attitudes of change into enhanced vaccines for our better estimation of how much more enhanced vaccines we'll be able to prepare or purchase in the following years. The reason behind our decision of first introducing smaller amount and gradual way of enhanced vaccines is not just because of money, but also the vaccine hesitancy issue among elders. You can see here from the graph that the influenza vaccination rate over the past decade has been only around 50% without obvious improvement. Three major reasons for not being vaccinated during our survey are first, worry about side effects, and also second, worry about interaction with the self-health conditions, and also the false belief that vaccines can make somebody easier to be sick. And in contrast, only 8% mentioned protection as an issue. So whether a more protective, better enhanced vaccine can really drive up the uptake is still questionable. During the policy discussion, a few other questions also were raised. For example, whether we should go to the extremely elders first to be at the first vaccinated group based on the analysis conclusion. However, we were also worried that based on the COVID-19 vaccine experiences, many non-related incidental deaths after injecting the extremely elderly group after the new vaccine would be inevitably frequent. And when media over-reports these events, the negative public impression questioning the new vaccine safety will be devastating for the policy. That's why in the end, we choose to go first to elders in the long-term care facilities who have already better vaccination rate around 80% and can be better monitored and managed by their caregivers. We also decide to purchase both enhanced vaccine, adjuvanted and high doses, given that they were determined as equally effective by our ACIP and also to allow for individualized consideration. Other concerns such as implementation, misinformation, media events will also be addressed to stakeholders and our local health partners carefully before, during, and after this year's launch. Besides endorsing new vaccines, how to increase elders' vaccine uptake is still crucial and is still our priority. We have been integrating influenza and the COVID vaccines into one campaign for the second year, and uptake is much better than 2024, thanks to the following driving factors. First, there was an unusual autumn influenza surge right before the October campaign, and the extensive warnings from the news and also from the medical groups become a major driving force for vaccination. Second, an earlier media coverage earlier last year of regional superstar Bobby She's death from influenza highlights influenza as a potentially severe disease, which became very motivating for many people's vaccination behavior. Finally, the community engagement and the outreach efforts were instrumental to promote vaccination as a happy and a healthy lifestyle. This slide shows some of the community activities we conducted, including collaboration with supermarket chains to have on-site vaccination service with store-provided rewards such as bananas and bottled water when customers get the vaccines. The private sector also invited a famous 69-year-old local actress on the right-hand side, whose nickname is the most beautiful auntie, as the campaign ambassador. She danced with the family doctor to create a vibe, and the auntie's video became viral online and made the concentration campaign fun and good to dance along. In summary, our policy pathway was in the context of addressing post-COVID challenges such as super aging, public fatigue, and reduced financial input. The lessons learned are while advocating priority and the investment in new vaccines, always put workforce first to win their support, not to overwhelm them with additional burden. And while evidence-based evaluation is crucial, be sure to address concerns carefully to gain public trust and prevent chaos. Community engagement is key to work against vaccine hesitancy. With these coordinated efforts, we will have a better edge in advocating more investment into the immunization programs. Thank you for your attention.
Excellent. Of using celebrities as spokespeople to get the message across in terms of the importance of vaccination. And then also, I think you also had a great example of how removing barriers by providing vaccines free of charge. And then also, as we discussed earlier, kind of meeting people where they're at. So actually targeting those elderly centers first. And I think it's really helpful and important to hear how different APEC economies are actually approaching this issue, including through the use of either pilot or small scale introductions first, and also just how you thought through it and what are some of the key questions that your group identified. I think that's very instructive for other APEC member economies. So next, we will move on to our next APEC leadership case, and that is from Japan. And so I'm very pleased to introduce Dr. Sayaka Takanashi, who is the chief of the Division of Immunization Policy, the National Institute of Infectious Diseases at the Japan Institute for Health Security. Dr. Takanashi her background actually spans clinical pediatrics, academic research, and national immunization policy, and she has been closely involved in evidence reviews and policy discussions related to influenza vaccination for older adults. And today she will walk us through Japan's pathway towards the introduction of enhanced influenza vaccines, including the role of surveillance data, effective evidence, and cost-effectiveness analysis. So Dr. Takanashi, thank you very much for joining us, and the floor is yours.
Good afternoon, and thank you for the opportunity to speak today. My name is Sayaka Takanashi, presenting on behalf of the National Institute of Infectious Diseases of Japan. In this presentation, I will share Japan's experience and current policy context regarding influenza prevention in older adults as part of our continued dialogue on reducing the influenza burden in aging societies. Let me begin by outlining today's presentation. First, I will briefly introduce Japan's National Immunization Technical Advisory Group, or NITAG. I will then describe the influenza surveillance system in Japan, followed by recent evidence on the effectiveness and safety of high-dose influenza vaccines. Next, I will touch on ongoing cost-effective analysis and finally conclude with key messages. This slide illustrates the institutional framework of Japan's National Immunization Technical Advisory Group, or NITAG. The NITAG is positioned as an independent advisory body that provides scientific advice to the Ministry of Health, Labor and Welfare. It reviews evidence on disease burden, vaccine effectiveness, safety, and economic evaluation, and discusses these issues through expert subcommittees. As shown on this slide, the Vaccine Subcommittee requests the National Institute of Infectious Diseases to create fact sheets to support vaccine evaluation. These fact sheets are intended to summarize scientific evidence in a standardized and accessible format to serve as a shared evidence base for discussion within the NITAG. To date, the National Institute of Infectious Diseases has developed fact sheets for 23 vaccine-preventable diseases. These fact sheets are publicly available and are regularly updated as new evidence emerges. The most recent fact sheet, issued on October 22, 2025, focuses on influenza vaccines for older adults, which is the main topic for today's presentation. This slide outlines the key components of the fact sheet on influenza vaccines for older adults. It begins with basic knowledge of influenza, including clinical characteristics, epidemiological features, and the history of vaccine introduction. It then reviews evidence on vaccine efficacy and safety, followed by an assessment of cost effectiveness. Together, these elements provide a comprehensive and structured basis for evaluating influenza vaccination strategies for older populations. Japan's influenza vaccination policy has evolved in a stepwise and evidence-based manner. In the 1990s, evidence was limited regarding population-level impact, which led to a cautious approach to routine immunization. As scientific evidence accumulated, particularly on preventing severe disease among older adults, Japan shifted toward targeted protection. More recently, with the approval of high-dose vaccines and ongoing cost-effectiveness evaluation, Japan is moving toward enhanced strategies for an aging society. Japan operates a comprehensive national influenza surveillance system that integrates sentinel reporting, virological surveillance, hospital-based monitoring, and mortality data. This long-standing system allows timely tracking of seasonal trends and circulating strains. However, like many economies, linking surveillance data to hospitalization, severe outcomes, and economic burden, especially among older adults, remains a challenge. Strengthening this linkage is critical for evaluating enhanced influenza vaccines and informing future policy decisions. To overcome these limitations, nationwide health insurance claims data from Japan's national database NDP were analyzed. The results show that influenza-related hospitalization, severe outcomes, and mortality are higher among adults aged 65 years and older and increases with age. This underscores the significant influenza burden in older populations. This phase 3 randomized trial conducted in Japan evaluated immunogenicity of a high-dose quadrivalent influenza vaccine compared with the standard dose formulation. Approximately 2,100 participants were enrolled across 10 clinical sites during the 2020 to 2021 season. The primary endpoint was the immune response after 20 days after vaccination, assessed by HI antibody titer. And seroconversion rates. Results showed that the high-dose vaccine induced significantly higher antibody responses across all 4 vaccine strains and achieved higher seroconversion rates compared with the standard dose vaccine. These findings demonstrate the superior immunogenicity of the high-dose vaccine, supporting its role in enhancing protection, especially in older generation. This slide summarizes clinical effectiveness evidence from a systematic review published in 2023. This review included 6 randomized clinical trials and 15 observational studies covering 12 influenza seasons and approximately 45 million individuals. Across seasons, the high-dose influenza vaccine consistently demonstrated superior effectiveness in preventing influenza illness and hospitalization compared with standard dose vaccines, regardless of whether circulating strains matched the vaccine antigens. Importantly, age-stratified analysis shows that relative effectiveness increased with advancing age, highlighting the added benefit of high-dose vaccine in older adults. This slide summarizes the safety data from a phase 3 randomized clinical trial conducted in Japan. The safety of intramuscular high-dose quadrivalent influenza vaccine was compared with a subcutaneous standard dose vaccine in approximately 2,000 participants. Local and systemic reactions within 7 days were slightly more frequent in the high-dose group. However, severe reactions were rare and occurred at similar rates in both groups. Serious adverse events were uncommon, comparable between groups, and none were considered related to vaccination. Overall, the high-dose influenza vaccine demonstrated an acceptable safety profile. This slide summarizes the assumption and methods of an unpublished cost-effectiveness analysis conducted by a Japanese research group. The analysis evaluated policy options, including high-dose influenza vaccines at different age thresholds, including 65, 70, 75, and 8 years and older. The price of the high-dose vaccine was assumed to be 5,000 Japanese yen, with full selection among the vaccinated people. The analysis was conducted from the healthcare payer perspective and included both vaccination costs and medical costs. Epidemiological parameters and vaccine effectiveness inputs were derived from published international studies, and vaccine effectiveness was assumed to last for 1 influenza season. This slide shows the results of the scenario analysis among adults aged 65 years and older. Among the evaluated policy options, introducing the high-dose influenza vaccines for adults aged 75 years and older demonstrated the most favorable cost effectiveness. As the eligible age threshold increased, the incremental cost effectiveness ratios generally improved, reflecting the higher disease burden in older age groups. These findings suggest that targeted introduction of high-dose vaccines to older populations may maximize health benefits while maintaining economic efficiency. This slide summarizes Japan's evidence to recommendation assessment for high-dose influenza vaccines. Older adults experience a substantial and increasing burden of severe influenza outcomes, as demonstrated by national database analysis. Evidence shows that high-dose vaccines provide superior protection against illness and hospitalization compared with standard dose vaccines, with acceptable safety and greater relative benefit at older ages. Cost-effectiveness analysis further supports the targeted introduction, particularly for adults aged 75 years and older, may offer the greatest value. Taken together, these findings support adding high-dose influenza vaccine as an option within the routine immunization program. In closing, Japan's experience suggests that targeting high-dose influenza vaccine to the oldest adults could maximize both health protection and economic value in aging societies. For APEC economies facing population aging, Japan's approach illustrates how evidence-based, stepwise policy decisions could support more effective and sustainable influenza prevention strategies. That's all for my presentation. Thank you very much for your kind attention.
Thank you, and good morning. I'm grateful for the invitation to attend this event and would like to thank the esteemed presenters, as well as the audience for joining us. What follows is a high-level presentation of our recent white paper focused upon the burden of adult influenza in Southeast Asia, a presentation developed for policymakers. I look forward to your thoughts. Today, I want to explore a critical question for our region. Is the true burden of adult influenza going unseen in the Asia-Pacific? Influenza is often treated as a predictable, seasonal nuisance, but the evidence and the lived experience of clinicians across the Asia-Pacific tells a very different story. My goal today is to highlight why influenza remains underestimated, how this affects older adults in particular, and what we can do to strengthen surveillance and protection across the region. My name's John Ryan McLane, and I serve as the Chief Executive Officer of the Asia-Pacific Alliance for the Control of Influenza, APACI. I've spent many years working across epidemiology, public health, humanitarian response, and diplomacy, and have yet to see influenza acknowledged for the threat it is. My PhD dealt with the 1918 pandemic, and surprisingly little has changed as far as attitudes are concerned. This work has shown me repeatedly that respiratory diseases, especially influenza, are both persistent and deeply underestimated threats. APACI's vision is simple but urgent: to reduce the burden of influenza and other respiratory diseases across the Asia-Pacific region. We were established in 2011 as a charitable institution based out of Hong Kong, and our membership includes hundreds of leading experts in influenza and respiratory diseases across Asia and the Pacific. We advise and complement WHO strategies, develop public awareness programs, support healthcare professionals, assist with country-specific recommendations, and work to improve access to vaccines and antivirals. Our role is to act regionally and globally to connect evidence, expertise, and policy so countries can act with confidence. As Jacqueline Katz from the WHO Collaborating Center reminds us, influenza is constantly changing. This is not a static virus. It evolves, it surprises, and it continues to pose pandemic risk. Being ahead of the game requires strong surveillance, rapid diagnostics, and the ability to detect unusual patterns early. Yet across much of the Asia-Pacific, we are still not seeing the full picture. As has been stated repeatedly throughout this conference, the Asia-Pacific is aging faster than any other region in the world. To repeat, in 2024, more than 720 million people in the Asia-Pacific were aged 60 or older, 15% of its population. By 2050, that will rise to more than 25%. For influenza, age is not just a demographic statistic, it is a risk multiplier. Once you pass 65, influenza becomes a serious threat, driving hospitalization, disability, and mortality, the classic old man's friend. This demographic shift alone demands a rethink of how we approach influenza prevention. Influenza causes between 290,000 and 650,000 deaths globally each year, with the highest burden among older adults. Across Southeast Asia, influenza remains a silent epidemic, persistent and overshadowed by other health priorities. 4 drivers shape this burden. Demographic change, the rapid aging increases vulnerability. Comorbidity crisis, the presence of NCDs amplifies severity. Complex seasonality. Multiple peaks in year-round circulation in the tropics and subtropics make planning difficult. And systematic underdiagnosis. Many cases are misclassified as pneumonia, cardiovascular disease, or chronic respiratory illness. Together, these factors mask the true impact of influenza. To better understand these gaps, APACI supported underlying research and helped to draft a resultant white paper across 4 pilot economies: Singapore, Malaysia, Thailand, and Vietnam. We asked one question: are we truly seeing the impact of influenza, especially amongst older adults? Through interviews with clinicians, public health leaders, geriatricians, and academics, we sought to uncover the real burden, identify gaps, and propose practical solutions that could be implemented within existing systems. Clinicians across 4 economies were clear. Adult influenza is a serious risk and a significant drain on resources. Experts emphasize the prevalence and severity of complications in older adults, despite public perception of minimal risk. In Singapore, we see high PCR testing costs, no self-testing, and older adults are underrepresented in ILA data. Malaysia sees uneven testing, delayed reporting, and the misclassification of severe cases. In Vietnam, providers report that influenza is not notifiable, leading to incomplete reporting. And Thailand sees reliance on low sensitivity rapid tests and voluntary reporting, which creates data gaps. These blind spots collectively obscure the true disease burden. Underdiagnosis is widespread, especially amongst older adults who often present with atypical symptoms. Influenza-related complications, pneumonia, cardiac events, COPD exacerbations, diabetes destabilization. These are all frequently coded under other conditions. This means influenza is hiding in plain sight within our hospital data, and the combination of aging, chronic disease, and complex seasonality amplifies risk, yet surveillance systems rarely capture this complexity. So what can we do? Vaccination remains our most effective tool, but uptake across the region is inconsistent. Clinicians identified the following factors contributing to suboptimal uptake. Singapore subsidizes vaccination for older adults, but uptake remains moderate due to low perceived risk. Malaysia lacks a universal publicly funded program, and vaccination is often seen as more travel-related than an annual precaution. Vietnam recommends vaccination, but has limited funding and access. And Thailand actually funds vaccination for older adults, but supply constraints and a short campaign window limit the coverage. Across all 4 countries, low risk perception among seniors remains a major barrier. Though high vaccine coverage alone does not guarantee protection. As Dr. Kuan presented earlier, South Korea's 2023-24 flu season demonstrated this clearly. Despite more than 80% coverage among older adults, vaccine effectiveness was estimated at only 13.5% for this group. This highlights the need for vaccines to provide stronger, longer-lasting immune responses in older adults. Differentiated vaccination strategies, incorporating enhanced vaccines, are essential if we want to reduce severe outcomes. High-dose vaccines have already shown significant public health impact globally. Countries using high-dose vaccines have seen substantial reductions in influenza cases, GP visits, hospitalizations, and deaths. In the United States, high-dose vaccines prevented more than 21,000 hospitalizations annually and generated an estimated $4.6 billion in savings over 10 years. These benefits aren't theoretical, they are real, measurable, and relevant to aging populations and their governments across the Asia-Pacific region. Please forgive a busy slide, but as this table shows, Model-based analyses working from a robust evidence base consistently show that high-dose vaccines are cost-effective and in many cases cost-saving. For governments concerned about budget impact, the message is clear. Enhanced vaccines are not only clinically beneficial, they're economically sound investments. To secure political will and financial support for expanded vaccination programs, we need accurate burden data. 3 priorities stand out. We need to learn from COVID. Regional countries demonstrated extraordinary capability in rapid testing and digital integration during the pandemic. We need to put that to use. Adopt enhanced surveillance, not just counting cases, but generating high quality, actionable data. And enable evidence-based policy. Better data allows us to optimize vaccine timing, identify priority groups, evaluate real-world effectiveness, and strengthen pandemic preparedness. Strengthening surveillance requires coordination across 5 areas. We need to leverage data to optimize vaccination strategies, including enhanced vaccines for older adults. We need to improve laboratory capacity by expanding PCR access and rapid molecular diagnostics. Enhance data sharing between ministries, academia, private hospitals, and laboratories. Strengthen the data quality with routine age disaggregated data, comorbidity indicators, and outcome tracking. And secure sustainable funding for sentinel sites, genomic sequencing, and communication campaigns. These steps are achievable within existing healthcare system structures. Experts across the region were united in their message. We must do more to protect older adults. They note, preventing influenza can also prevent heart attacks, strokes, and other comorbidities. The governments have strong evidence to invest in vaccines for the elderly, and that we now better understand the importance of life course immunization. Their voices reinforce what the data already tells us. Action is possible, and it's overdue. To close, the true burden of influenza in APAC is still not fully clear, and that invisibility has consequences. Aging populations, chronic disease, and complex seasonality demand stronger surveillance and more effective vaccination strategies. Enhanced vaccines, improved diagnostics, and better data systems offer a clear path forward. If we act now, we can reduce hospitalizations, prevent deaths, and support healthy aging across the region. We can be ready for the demographic changes we face and the respiratory diseases threat these will produce. Thank you.
Good day, everyone, and welcome. I'm LJ Tan, and I'm the Chief Policy and Partnerships Officer at Immunize.org. I also chair the United States National Adult and Influenza Immunization Summit and the Global Influenza Initiative. I just have to say that any opinion that I express today is strictly mine and do not necessarily represent positions of the summit, nor the GII, nor my employer, Immunize.org. I am obviously delighted to be here, and I want to thank the organizers at APEC for inviting me here to discuss the recently published FLUNITY-HD study. First, a couple quick disclosures for you all to be aware of. I have no conflict of interest, but I do need to specify that the study that I'm about to describe and discuss, which comprises FLUNITY-HD, DAMFLU-2, and GALFLU, was funded by Sanofi, who participated in the study design, the protocol development, and manuscript review phases, but had no responsibilities in terms of trial conduct, data collection, or, importantly, the data analysis. So, at this APEC meeting, you've already heard multiple speakers, including Drs. Ng and McLane, communicate to you the burden of influenza, especially to the aging population, and that many of your economies are becoming super aging economies, where more than 20% of your population is aged over 65. And so the importance of managing the negative impacts of influenza is great, and I'm not going to belabor that point, but will briefly, in the next few slides, remind us again of that burden of influenza. So This slide talks about some of the morbidities and some of the mortality impacts of influenza. And what we want to recognize is that when influenza infects somebody, it triggers many events, specifically a cascade of events, which includes inflammation and a cytokine storm. So what exactly is that? So obviously inflammation is when your body inflames. You get a lot of immune reactions that actually non-specifically drives the immune system. And a cytokine storm is essentially that as well. It's a whole bunch of chemicals that your immune system releases, such as IL-1 and gamma interferon and things like that, that actually inflame your body further. And then when you put that on top of some already persistent inflammation that we have in particularly those over 65, this condition that we call inflammaging, it can actually lead to really severe negative impacts and severe complications to the body, particularly in those over 65. I'm not going to go through this entire slide and talk about all the different impacts that you see here, but this is just to highlight with the red circles 4 specific places where I think you can see a dramatic impact of influenza on morbidity as well as potential mortality. So if you take a look at the left-hand side, I want to remind everybody that the data now with regards to cardiovascular disease is extremely strong, and that there is about a 10-fold increased risk of heart attack in adults who are 40 years of age and older within 3 days after they get influenza infection. And then if you take a look on the right-hand side, about 56% of people have an increased risk of pneumonia or asthma or COPD who are in people who are over 50 years of age. Then I want to point out that if you think about adults with type 2 diabetes, there's about a 74% increase in glycemic events as a result of influenza infection. And then if you look at, and this is for me one of the more important points for older adults over 65, 23% of them will experience some loss of independence following infection with influenza. What I like to say with this example is that if you're an older adult over 65 years of age, a lot of them, when I talk to them, they don't come to me and say, LJ, I'm worried about, about death. A lot of them have kind of worked through some of those issues. What they talk to me about is their quality of life. The fact that even though they are over 65, they're still enjoying the benefits of being able to cook, some autonomy in terms of going out with friends, etc., etc. And that's what they value, that quality of life. And what I tell a lot of people is that if you are unvaccinated and over 65 and you catch influenza, you may walk into the hospital, but there's a good likelihood that 3 weeks later you could come out with a walker. So in other words, you have this loss of quality of life. And I think that's something that we sometimes don't emphasize enough for our older adults, this loss of independence that they might suffer. The other thing I want to point out also, and this just kind of highlights a little bit further, and I'm not going to spend a lot of time on this, is that among unvaccinated people, this slide kind of shows you this on the left-hand side, reminding us that 1 in 5 children who are unvaccinated will be infected with influenza. And then to remind that these infected children will actually transmit that disease to adults, as many of you have already known. When that school season starts, your kids come home and all of a sudden, there's respiratory diseases transmitting through the family. And influenza is indeed one of those. In unvaccinated adults, just to remind us, 1 in 10 will become infected. And the biggest challenge with these infections is when they happen in high-risk populations. And that's where I want to draw your attention to some of the things on the right-hand side. Because when you have a high-risk population, their risk of hospitalization, their risk of death increases dramatically. And this is what you see on the right-hand side. I'm not going to belabor the point, but reminding us all that we're talking about older adults. 67% of influenza-related deaths are in adults 65 years of age and older. And then with adults that have chronic immunosuppressive conditions, for example, there's a 4-fold increased risk of death in them. And so we need to really do our best to prevent influenza as best as we can in these compromised, in these older, high-risk groups. And when we want to protect against these high-risk groups, obviously we would like to protect them against getting disease. But that's not the most important thing. We want to also try to protect them against some of the complications from catching influenza, because it's the complications of influenza that can result in multiple in cost to your economies. And that's what I'm going to go talk about on the next slide, these complications. Before I go there, just to remind everybody once again that approximately 4 people die from influenza every 5 minutes around the world. So this slide points out to me is that
while there are certainly costs to your economies from a case of influenza, it is when there are severe outcomes, as what we see in the aging populations, the populations who are immunocompromised, or the populations with chronic illnesses, that we see the escalating costs to the healthcare system. And this is what I want to show you on the right-hand side of the slide. So when you have an attack rate of about 2 in 1,000 will end up going to the emergency room, and as these older adults, as these adults with chronic illnesses get infected with influenza, they tend to go towards that right-hand side. They tend to end up going to the emergency department. They tend to end up going into hospitalizations. And when you go into that right side of this slide, you can see the cost to manage those cases become much greater. And that is a cost to your healthcare system. That is a cost to your economy. And finally, this is a study that has just been put into preprint. It is still undergoing peer review, but it is an economic analysis. And on the left-hand side, what I point out is this is an analysis of the total cost of influenza, which includes healthcare costs as well as productivity costs, okay, by age category for one influenza season in the United States. So we're looking at the 2023-2024 flu season. This is 2 seasons ago, and that was, if you remind everybody, was a fairly severe flu season in the United States. And as you can see here, the cost to the United States economy because of that one severe flu season with regards to healthcare and productivity losses, $28 billion, almost $29 billion. And then what I want to point out then is on the right-hand side, what the right-hand side graph shows us is actually, oh, and in fact, my camera is blocking that right-hand side. So I'm going to try to see if I can turn that camera off, and I don't know if I can. Oh boy, let me see if I can do this right now. I am not able to turn off that camera. Well, but what I'm going to try to point out to you on that right-hand side is that what this study did, which was actually quite which is novel, is that it actually said what happens to that cost burden if we had vaccinated in that season the best that we've ever done. So not saying 90%, not saying 80%, but basically saying, you know, what's the best coverage rates the United States has ever accomplished with influenza protection? And that happened right after the COVID started. So that was the 2020-2021 season. And when we had a very nice vaccination coverage rates against influenza, because everybody was trying to do something when they couldn't get vaccinated against COVID, they're protecting themselves against flu. And so using those coverage rates, you can see that we're saving potentially $25+ million worth in terms of costs just by doing a little bit better in terms of our vaccination coverage rates. So something to just kind of keep in mind, why it is so important for us to continue to work hard to improve protecting our populations against influenza. So what makes a vaccine better is what I'm going to kind of touch a little bit, because that will take us into our discussion about the FLUNITY-HD study. So I've kind of suggested this already with influenza. We've been talking about this a lot, and this is probably true for all adult vaccines as well. And that is, you know, with adult vaccines and seasonal influenza vaccines, not only do you want to demonstrate efficacy against preventing disease, that is definitely important. You want to see how well the vaccine protects you against getting influenza itself. But I think also really important, and that's you can see the clinical endpoint that we're measuring, infection data, as you can see there. But also really, really important, especially for adults, and especially for adults who are older, especially adults who have high-risk conditions, is that we need to show that we can protect them not just against getting flu, but also against the complications from influenza, like hospitalizations. And remember, hospitalizations are one of those cost drivers for your economies. When people get hospitalized, your costs go up. And so I think one of the things we want to kind of show with a better vaccine, is that it not only protects against infection, but it also protects against these severe complications for influenza. And we want studies to show that a vaccine is better using robust methodology, right? So when we say that, what do we mean? We mean that, you know, obviously we do immunogenicity study, which is the current minimum for licensure, but we want to do these studies such that they're individually randomized so that we can show causation. We can show causation between one and the outcome. We want a standard dose as the comparator. That should be the minimum comparator. And then these results should be consistent across study design and across studies and across seasons, right, and study designs as well. And I think this is where and so this leads us into what we call randomization. And I think randomization is what is fundamental in proving that something works. And just to remind us, we do randomized controlled trials, randomization, in not just vaccine studies, but also in all studies, right? Because what we can do with randomized clinical trials is that we can establish a causal relationship. And that's because it is the gold standard when you take a study population and you split it into a group that receives the experimental and a group that receives the comparator, whether it be a control or whether it be a comparative vaccine. What you can do now is you can eliminate biases, right? Because they're equal and randomized. And it allows us to measure very precise treatment effects. However, it's extremely expensive and it's resource intensive, and often you do not get the sample sizes that you need. You need large sample sizes sometimes to show a very specific, precise treatment effect. And so sometimes it's just not practical, and you can't do that kind of large randomized clinical trial because it's just too resource intensive. On the right-hand side, we have something called observational studies, and this is what's actually done in the real world when the vaccine is actually being used, and then we can actually go out there and we look at the real-world evidence and we see whether there is clinical benefit. We can confirm what we saw in our randomized clinical trial using the observational study in the real-world setting. So unfortunately, there are some challenges here. While you can actually get access to much larger populations because the vaccine is already being used and it's being used over multiple years, and they're fairly easy to conduct, these observational studies, they're not perfect, right? They're complex. You need to do statistical methodology to kind of show statistical significance. And there are always going to be biases and confounders because in the real world population, you're going to have in the treatment group and the control group, as much as you try to control for those confounders, there will be differences. And so it's not the best way to show causality unless there is a way to randomize an observational study so that you can actually then make comparisons. And I think we can now do that. So this now takes us into this idea of how large do you need something to be in order to show and assess severe disease outcomes. I kind of suggested this when I talked about the comparison between a randomized controlled trial, the RCT, and obviously the observational studies. And this kind of suggests to you that in order for something to be adequately powered to demonstrate an enhanced vaccine superior protection versus a comparator of a standard vaccine, you need over 300,000 sample sizes. So in other words, 300,000 people have to be participating in this study in order for us to be able to see, to assess an outcome. And so, as I said, we can now do this in the real world setting by randomizing an observational study. And that is what FLUNITY-HD has done. It is an individually randomized study. So that's when we're randomizing. That's the gold standard because it minimizes bias. But we're combining it into a real-world setting where we can get a large sample size and we can then do subgroup analysis. And so FLUNITY-HD looked at 466,000 older adults across 2 geographical areas in Denmark and in Spain, and across 3 influenza seasons. So as a result, this study is adequately powered to look at some of the severe influenza outcomes and protection against those severe influenza outcomes that we are so interested in. So in other words, when we give the enhanced vaccine, is that better than the standard vaccine against cardiovascular disease, respiratory outcomes, etc., etc.? And this indeed is the largest individually randomized influenza vaccine effectiveness study to date. And so again, this is necessary because until now, there has not been an adequately powered study to assess the difference between a high-dose inactivated flu vaccine versus the standard dose inactivated flu vaccine against those severe outcomes of influenza that we were interested in. And so DanFlu-2, which was done in Denmark, combined with GalFlu, which was done in Galicia, Spain, combined together to give us FLUNITY-HD. And I want to remind people that what is great about this study, and you're going, hey, wait, these are two studies. How come you can kind of combine them into FLUNITY-HD? Is that this was a pre-specified study. So in other words, it is a pre-specified pooled analysis of two methodologically harmonized, pragmatic, individually randomized trials. So the investigators got together at first, they agreed on the methodology, it was pre-specified, the pooled analysis was pre-specified, they did their trials, and then they came back and combined the data. So in other words, it's not like one went off on one side, one went off the other side, and they're trying to combine this together, shoehorn these results together. No, this was methodologically harmonized before the trials started. And that's what's beautiful about them all. So if you can see this, first DanFlu published in New England Journal of Medicine, GalFlu published in New England Journal of Medicine, the combination published in Lancet as FLU-HD. And that's what we're going to be finalizing the results on today. Just to remind everybody, let's talk a little bit about the results here. Again, both the GalFlu and the DanFlu combined into FLUNITY-HD demonstrated superior protection for the enhanced vaccine against the standard dose vaccines against multiple severe outcomes that they were looking at. Now, the primary outcome was actually hospitalizations for pneumonia or influenza, and as you can see, there was about an 8.8% improvement of the high dose influenza vaccine over the standard dose influenza vaccine. So that is a significant improvement over the standard dose influenza vaccine. And then some of the secondary endpoints they looked at included hospitalizations for any cardiorespiratory disease. They also looked at laboratory confirmed influenza hospitalizations. And that obviously is going to be the most specific because you're looking at a lab confirmed influenza hospitalization. So because it's influenza, the vaccines against influenza, you're going to anticipate that this is going to be the most effective. And indeed, we see that as well. This is the biggest improvement of the HD over this SD is indeed in this lab confirmed flu hospitalization, over 31, almost 32% better. And then all-cause hospitalization, which is hospitalization against anything, it was a 2.2% improvement between HD and SD. And so I think what this definitely shows us all, and I'm going to kind of go into a summary slide, is that it definitely shows this enhanced vaccine certainly does indeed provide superior protection beyond just preventing flu infection for adults, right? So this is where I come back to that first point. Our flu vaccines need to prevent against people getting sick, but importantly, if you have an older adult or somebody with a chronic illness, it needs to also reduce their complications and specifically hospitalizations. So if you take a look at hospitalizations, it prevented over standard dose, right? Lab confirmed influenza 32% almost, pneumonia and influenza almost 9%, cardiorespiratory about 6%, and all cause about 2%. The other thing I also want to point out to people is that they then took a look at another secondary outcome, which was the ability to take a look at the cardiovascular outcomes. And this was recently published in Circulation magazine. You see this on your slide with the QR code if you want to take a look at that data. And I want to point out that is with the pre-specified secondary analysis. So this again was pre-specified analysis from both those studies combined into the FLUNITY-HD, which was then published in Circulation. This looked at cardiovascular outcomes. And specifically what they were looking for are all the primary and secondary endpoints according to the history of CVDs, or cardiovascular disease. And they looked specifically for hospitalizations against any cardiovascular disease, stroke, etc., as you can see on this slide. And so what did they see? This is what they saw, that with regards to these top 4 hospitalizations for these outcomes, the high-dose influenza vaccine significantly reduced hospitalizations when compared to the standard dose influenza vaccine. And in particular, if you look at that 4th one from down, which is the hospitalization for heart failure, there was a 23% improvement over the standard dose in terms of preventing hospitalizations because of heart failure. But Hospitalizations for any cardiovascular disease, any cardiorespiratory disease, any respiratory disease, all showed significant improvement in terms of reducing hospitalizations when compared to standard dose vaccine. And so this is the conclusion. Among specified cardiovascular outcomes, substantial benefit against hospitalizations for heart failure, consistently reduced severe hospitalization outcomes regardless of previous history of cardiovascular disease, and also prevents more hospitalizations in people with cardiovascular disease. And that is because they're already at higher risk, as we anticipate. So finally, these are the incredible team that I'm just presenting their work. If it wasn't for their work, I wouldn't have this to present. I was not part of this study, but I'm honored to present this incredible study that was done by the researchers in Denmark and the researchers that were done in Galicia, Spain. I think what is important for us to come back to is to remind all of us is that influenza is a shapeshifter. It always comes back. It always comes back. Think of subclade K. And when it comes back, it's never the same. And reminding all of us is that when you have seen one flu season, you've seen one flu season. The only thing certain about influenza is its uncertainty. But one thing we have shown with this, what we see with this FLUNITY-HD study is that the enhanced vaccine does indeed provide superior protection over the standard dose vaccine for the older adults in some of these high-risk complications that we are interested in. Then this is, of course, beyond protection against disease itself. So it is a predictable, unpredictable creature. Thank you all very much for your attention, and appreciate the opportunity to record this for you all who weren't able to be there live.
One of the questions is that we've heard a number of examples today in terms of how data on the burden of and vaccine effectiveness, cost effectiveness are informing policy. From your experience, what is the most important enabler that helps move an economy from evidence to implementation? Is it the need for better data? Is it financing mechanisms? The provider engagement? Is it something else? Maybe I'll just kind of direct it to our speakers that are here in the room. If you have any thoughts in terms of what is kind of that most important, or maybe just like a key important enabler that helps move an economy from evidence to implementation?
Well, certainly presenting the evidence in a cost-effectiveness form is an absolutely essential first step. You have to accept the fact that many of the policymakers we'll be working with have a limited amount of time to become very literate in very specific health issues, and instead present it to them as a matter of resource allocation. Along with that, I found a great deal of efficacy in taking advantage of the size of the cohort that we are talking about. As we're talking about somewhere between 15 and 25% of the population of my region, the Asia Pacific, either now or will shortly fall into that over 60 age group. That is a huge segment of the population with the political weight and the economic weight that comes from that. So if you can identify spokespeople that reflect accurately and are respected within that cohort that can speak to the policymakers in a given economy regarding the interests of that cohort, then you can actually put that heft to use within the political structure of the given economy we're speaking of to press for those resources to be allocated in this way.
Professor Ng or LJ, do you also want to comment?
Just a quick point. I think policies by nature are blunt. Because they are blunt, that's why implementation has to be as sharp as possible. So from an implementation perspective, typically, most of our policy concept implementation assumes one size fits all. But I think the presentation by our colleague from Chinese Taipei, I thought brought up a point that resonated a lot with me. He was talking about vaccine hesitancy among older adults, and about 60+% worry about side effects. 20+% felt that flu vaccines weren't possible because of current health conditions. If we communicate one way, it's not one size fits all approach. In fact, what would resonate for those who are hesitant because of side effects, we need a different strokes for different folks approach, right? So the idea for these people is to say, look, debunk the myths about side effects. Then for the other groups, it may be reasons that resonate with them. So I think the point here is we need to move away from a one-size-fits-all approach to a different strokes for different folks approach. Then implementation can be as sharp as possible.
I don't have much more to add except all the above. I think all three are important levers. They need to be holistically combined, right? I think you can't do one without the other. So supporting everything that's been said by John and Reuben, I think you can't educate the public and tell them that they have a better vaccine if you don't have ways to get them the better vaccine, right? At the same time, you can't just go ahead and implement a policy just that's blunt without a way to integrate that policy into actual delivery of vaccines to the public. So it's you got to move them all at the same time. So I think that's very fundamentally important. What I do think is that it's economy specific. And that is for Reuben's point as well, is that, I was noting with Dr. Wong's one study that his effectiveness of flu vaccine was really low. Ours in the United States for that same flu season was significantly higher. So I think you got to take a look at the data individually at your own economy and decide, what is the data that's going to drive the questions that you're hearing. If it is about safety, you need safety data. If it's about, hesitancy, you need hesitancy data. And if it's about effectiveness, then you need effectiveness data.
And actually continuing, we actually have a number of kind of different kind of questions that are kind of focused sort of around data. I think I'm just going to paraphrase a couple of questions here and kind of follow on to that discussion. So for the economies that currently are kind of lacking strong local burden data, are there any kind of practical kind of first steps or things that they can start to begin to do to kind of strengthen their influenza surveillance and start generating that policy relevant data?
Sure.
Yeah.
Well, coming from New Zealand, we've had a program for many, many years called Shivers, which was supported by CDC and other sources. And why the Northern Hemisphere would fund Sentinel sites in New Zealand is because it allowed them to determine what the next year's vaccine should look like. It was critical, both directions. And there was a vested interest in establishing Sentinel sites in the Southern Hemisphere. New Zealand worked out quite well, and it has been extraordinarily beneficial for our own internal vaccination system. I would suggest as a first step for states that are looking to really take a look at what the burden is and how to address it, that you need Sentinel sites to be stood up, and they need to be sustainable. And it needs to be broad enough so that you aren't generalizing just urban areas or just rural areas, but across a given economy. There does not need to be a huge number of them necessarily, but they do need to reflect the breadth of the population and the settings.
We got it.
Okay, perfect. Okay, excellent. Okay, so another question here is, what opportunities do you see for APEC economies to collaborate more closely on influenza policy, whether it be surveillance, data sharing, evaluation of vaccine impact? Are there things that APEC as a kind of a regional body can be working on that would be useful?
Let me start with that, and I'm going to turn to John and Reuben because they are obviously APEC here, right? So I think it's important to think about collaboration across your recommendations and policies. I think we've seen this in in Europe, where when you have multiple European Union countries implementing different policies with regards to vaccinating their elderly, all of a sudden there's confusion, right? Because if Poland does this, and the United Kingdom does this, and the Netherlands does this, there's a lot of confusion in the messaging to the public. And I think across APEC economies, I think it's useful to talk about the data that reached your goal of 75 versus 65. Because that when I heard that in Japan versus Korea, for example, Chinese Taipei, I got concerned. I was like, okay, so what does that mean? Are they looking at different data? Or if they're looking at the same data, what is the cost effectiveness that they're looking at that made them shift between 65 and 75? All that needs to be harmonized and expressed publicly and transparently so that people know how these decisions are being made.
But my thought is that most of the time when it comes to flu and flu vaccinations, the policy owner is typically the health ministry, right? Or the minister or secretary of health. I think today's discussion has made us understand that it's just beyond health. It's really about protecting aging populations, it's protecting our economies, making them resilient. So I think this kind of intelligence is very important, which means that the health minister or the secretary of health can then work together with the secretary of industry, secretary of family and population or demographics and things like that to really increase the sphere of influence from health through vaccines being a health issue to a whole government kind of issue. I think something to think about.
And finally, I would throw in never let a good crisis go to waste. At the moment, with the basic collapse of the multilateral funding system for influenza research globally, when moments of change like this is when the vested parties, the interested parties, the experts need to come together and try to use the moment of change to create something better in its wake. And that, across the APEC region, policymakers, experts, researchers, academics coming together to discuss what this should look like, what the next iteration should look like, because we no longer have the inertia of the former system or the resources of the former system, and we need to develop something new.
Ryan, remember, influenza respects those borders, so regional collaboration seems really.
Okay, so before I ask you all for your kind of parting thoughts, or just like kind of one thing you want to kind of leave this audience with, I'll just kind of turn to my colleagues to see if we are able to get either our Japanese or okay. So since it is almost 4 o'clock, and we are running up against time here, I'll just give my colleagues here in the room an opportunity if there's any kind of final thoughts you'd like to leave with our audience.
Demography comes for us all. It's the change is coming. We're already in the midst of it, and it's going to accelerate. Influenza is a particular risk for the fastest growing segment of our population, and we will address it either in advance or we will address it when it is a crisis in our midst.
Wow, that's a good one. As I said, influenza is a keystone into getting all your patients vaccinated against adult vaccines. Just a reminder, it is dangerous in adults to use primary infection as your only outcome of vaccine effectiveness, relevance in terms of measuring that. I think you need to look more than that. You need to look at the morbidity measurements like quality of life, hospitalizations, et cetera, especially with the older adults. And I think it's really, really important to remember, follow the data. If we keep saying that we're evidence-based, if the evidence base is showing enhanced vaccines make a difference, then you need to follow that.
I think we really need to get a word out. I meant it. I wasn't joking about it when actually talking about the size of conversations around flu and flu vaccines. I mentioned just now, right? We talk about CARs 50 times more than flu and flu vaccines, bubble tea 2 times more. So it just means that there's a lot more work to get the word out, and it's really important to create that groundswell so that it's not us. Policymakers, think tankers, and academics talking about it. We need that groundswell to move the world towards enhanced flu vaccination.
Excellent. Well, thank you very much. I had some summary points, but I think you guys did a fantastic job. So I think I'll leave it with that. So if you could give a round of applause for all of our speakers. Excellent. Okay, so then just in terms of next steps, so we will be developing a report that will be coming out of this meeting. So I know we did have some technical issues with some of the audio online, but we will be developing a report that will be circulating to all of the APEC economies. So don't worry if you're online and you had missed some of the proceedings here. We will be summarizing this and sending that out. And then if everyone has been to an APEC meeting yet these past 4 days know that no APEC meeting is complete without a family photo. So we would like to call everyone up to the front here. We can stand behind this screen here. And then if there's someone who is rather acrobatic, maybe can hop over the table and take a picture, that would be fantastic. But if I could have everyone come up to the front here, we'll take a family photo. And then after that, we will also be having a small reception in the Marriott Hotel. So you can take the buses to the Marriott, walk straight back, and we will be on the left-hand side. It'll be right across from the bar in the lounge area. So we all welcome you to come back with us to the Marriott Hotel for a small reception, continue the discussions, have a bite and a drink, and have any more reflections on this discussion?